Hello, everyone. Thanks so much for joining us for this afternoon session. We promise this will be invigorating and keep your eyes wide open as you go through that postprandial slump. So my name is Nate Morse, and I'm with the Maine CDC, and I'm in charge of the Diabetes Prevention and Control Program. And I want to thank the Coalition for inviting us to actually put together a panel of folks from around the state, both from employers and health systems, who have been working to scale and actually deploy a program around providing primary and secondary prevention strategies for individuals who are at high risk or with prediabetes and at risk for developing type 2 diabetes. So our discussion today is actually really about all of these guys. So I'm just going to provide a quick overview for all of you about what is the National Diabetes Prevention Program and what it aims to do, and our vision across the country, as well as what we're doing here in the state of Maine. A lot of our effort right now is combined around both US CDC federal funding opportunity, and as well the State Innovation Model Grant has helped really breathe a lot of life into moving this initiative forward and deploying it for our communities around the state. So we're really excited about helping this program get to all of you, and our hope is that at the end of this, and I'll go over the learning objectives here in a second, is that all of you are able to take some action steps from here moving forward in order to start thinking about how you might be able to apply this strategy within your setting as well. So first I want to introduce the group here of our panel. We have representatives from the health systems environment, and we're very happy to have Dr. Barbara Crowley here from Maine General. We also have Michelle Eldridge from the Dartmouth practice and Maine General practices. Laura Holweger, who's in charge of the program manager for the Prevention Center on the National Diabetes Prevention Program effort and the Community Transformation Grant that they have. From our employer group, we have Susan Tufts from LL Bean, little business you guys might have heard about up the road, and also Anthony Anderson from Bath Iron Works here, and all of them are hoping to share a little bit about their success. So this is your bright spot examples about those who are really working towards preventing the onset of type 2 diabetes for individuals here in the state of Maine. So first off, our goal with this whole session, in order to help all of you, we want you to start thinking about how you could potentially apply this program to some of the other healthcare system, delivery system innovations that you're working towards, also your payment reform efforts. So National Diabetes Prevention Program could potentially be a great fit for your accountable care organization. Perhaps it's something that you're considering, or you might want to consider, for a value-based insurance design effort. In addition, we're hoping at the conclusion of this, you're thinking more about how you might be able to apply primary and secondary prevention to your population health strategy for your organization, for your employees, perhaps your community. So, and then finally, we really want all of you to walk away from this session, knowing that there are resources out there that you can tap into, both from the community sectors. We have examples of where this program is being deployed across the community, in work sites, but the resources are there to assist all of you in being successful in making that happen. And we will provide, and just so all of you know, I'm currently the person providing technical support for a lot of that for the state of Maine. So we do have a few resources up here at the front on the front of the stage, and if anybody needs anything, you can come up and grab those at the conclusion. As we run through the session, I want to ask everybody, if we can, try to keep our questions to the end, so we can have time for everybody to run through, and we'll get to your questions at the end. But if there's something real burning, please go ahead, raise your hand. So first, I want to talk about the picture of both prediabetes and diabetes in our country and here in Maine. For the United States, we have a growing problem. Probably best to start with the distinction between the two conditions for the audience. That prediabetes is actually defined as having abnormal blood glucose in addition to other risk factors that are not yet within the diagnosis range of diabetes. And for individuals who present with prediabetes or high risk for prediabetes, really have a unique opportunity to reverse the onset of type 2. And this phase, this period of time is so critical to help people reverse or potentially delay the onset of this condition. So the program all of us are talking about today really is about that early intervention, not waiting for an individual to have an A1C greater than 6.5 before intervention is offered, but really getting to them when perhaps they might be a little more ready for change, that they may not be daunted by a new diagnosis. And this program actually offers a really simple way, a very concrete way for folks to establish some very simple lifestyle and behavior change options for themselves. So with the picture across the country, I mean, just 2 years ago, we saw roughly around 79 million for diabetes rates here in our country. But as you can see, we're really dealing with a much more significant issue. Is a lot of folks don't understand that they have these conditions. So part of this effort is to really be thoughtful and careful about helping individuals identify, whether they're at risk or not, and guide them to that process of establishing good lifestyle and behavior changes through programs such as NDPP. So we may use that acronym in this discussion here, NDPP, referring to the National Diabetes Prevention Program. This program was actually based on very strong evidence and research. The National Institute for Health, or NIH, conducted a study that proved that for populations 18 to 60 years of age, that there is a 58% effectiveness of preventing or delaying the onset of type 2. For populations greater than 70 years of age, it actually had a 71% effectiveness. And this was directly compared to a placebo as well as a pharmacological intervention of metformin. But there's several simple predictors that we need to consider as well around this program, is that folks can do simple things like work on reducing their weight, and I'll get to that in a second, and then also work on reducing their fat gram consumption. Those are some of the simple principles that are involved in the program, but these guys will tell you more about it here in a minute. This is not something that is small and only growing out here in Maine. Actually, just this summer, we crossed the threshold of over 1,000 National Diabetes Prevention Program provider sites in the country, and this is growing every day. So here in Maine, we are really fortunate to have 13 US CDC recognized programs here in our state, and this is an effort that we are trying to drive further through the State Innovation Model Grant as well, establishing more programs and deploying this statewide. So, our overall goals that we wanted to make sure were covered here is that we want this whole effort to be sustainable. And there is a way to do this if we break it down to that population health approach. We also want all of you to, as I stated before, walk away from this session thinking about the different sectors that you could potentially collaborate with in order to scale and deploy this type of intervention to the different types of folks in your region. So don't think about, I have to own this all myself. Don't think about, there are different types of organizations and providers that may be in your region who could help you scale this program and offer it to the eligible population. And finally, we have to look through the lens of sustainability. So we want to help all of you, as well as the payer community, bring this to scale appropriately so that it can be carried throughout the future. So I'll turn it over now to our distinguished panel. So Laura, take it away.
You did a very thorough overview of the program, so I'll try not to repeat. But we just wanted to give you a little bit of an overview of kind of a clinical representation of what we've done with the Diabetes Prevention Program. So the Prevention Center at Maine General received a federal 2-year Community Transformation Small Communities Grant, and that was very instrumental in being able to have us offer as many as we have over the last 2 years of the programs. So that grant paid for one full-time staff person, which was me, that was really a mover and shaker in the community and with internal in our clinical setting as well. So that's a huge part. I don't think anybody else in Maine has one person that can kind of really go out and go into the community and really try to move this program forward. So why we asked? So just our focus area. Our focus area for this specific grant was just Kennebec and Somerset County. So just in those 2 counties, we had roughly 90,000 people that are at risk for diabetes. So that's about 60% of our population. We kind of look at the iceberg. So at the tip of the iceberg is smaller, but the bottom of the iceberg is our individuals with pre-diabetes. So what if those 90,000 went to the top of the iceberg, it would flip it over. So we really are looking at trying to prevent chronic disease, turn some things around, and reduce the overall cost for individuals developing type 2 diabetes, which is very costly. We really worked towards enrolling individuals that, like Nate said, that are at risk for type 2. And we have actually a screening tool that was developed through the CDC. And I have some down here on the front of the stage if people are interested in checking that out. But it's roughly 6 or 7 questions identifying if you're at risk. And people can self-refer to this program, so they don't need a referral from their provider, although that's helpful as well. But people can self-refer to this program if they're at risk. And then we do look at, if those individuals have elevated glucose levels as well. So like I said, whoops, really advances quickly. So like I said, that the single leader, having someone in a community setting that can really make those key contacts and identify leaders within the community that are willing to partner and better their community and health outcomes for their community is really important. Another key component is we implemented at the Prevention Center a centralized hub system, which is actually one phone number, which you'll see on this lovely little card that we have and all of our other materials that we have. And that phone number is staffed Monday through Friday, 8 to 5 or 8 to 4:30. And it's really nice for someone to actually have someone to talk to. And we have quite a few people that actually called and say, I have diabetes, what do I do? So with that, we identified that we have a population that we're missing that really need the extra help, that have already been to the Diabetes Nutrition Center. They've kind of gone through the DSMT program and they need a little bit extra help. So from that, we implemented the Stanford Living Well with Diabetes program to help bridge that need in the community. So that hub system is really key. They register people, they go through to see if they're at risk. They ask what their latest glucose numbers were. We do registrations, we do reminder calls, and it's a very comprehensive process that we've luckily been able to have that resource. And then we really worked hard to write reports within our EMR, and that's just internal and Maine General, to identify individuals within each practice who technically are diagnosed pre-diabetic. So we're able to run that EMR report and work closely with specific practices saying, this is your total patient population. The ones on the top here are the ones that are diagnosed with pre-diabetic. So let's try to get them plugged into one of these free classes that we have going on in the community. And I have anywhere from 3 to 5 programs that I launch every month in different areas in Kennebec and Somerset County. So they're all 8 a.m., some are noon, some are at 5:30 at night, and all different days throughout the week and even weekends, to try to diffuse some of those barriers for people. So like I said before, meetings with leadership out in the community, we have some amazing key partners like Spectrum Generation, KV a lot of other individuals in our community that are really helpful in implementing this type of program and help lead us to success down the road with looking at expanding this program. and also in the clinical setting, done a lot of meetings and one-on-ones with practice leaders, practice administrators, primary care providers, going to staff meetings and really making sure that the word is out there that there is this resource that's free to our community that they can get their patients plugged into. And the providers really like to see that one centralized hub number that they can call to get all of the classes that are coming up in the next 6 months, either with our chronic disease management or the diabetes prevention program too. So this is just a little project timeline that I created since this was a 2-year grant. If you can really see that, might be a little bit small for people, but just to highlight at the top, the first year I launched 16 programs within Kennebec and Somerset County. We trained 39 lifestyle coaches to deliver this program. And within the EMR, we only had 22 referrals. So again, that was a process that evolved and continued to increase over time. And then the screening tool, we had about 10,500 delivered out in the community, either through Facebook or our Movers and Shakers in the community or through our newspaper ads. We wanted to get this screening tool out to all of those 90,000 people in our community to identify what their risk was for diabetes. So you can see here too that 22 EMR referrals went up to 82. So it slowly gained headway. What we also saw with individuals signing up and registering for programs is that individuals that went through the program and had amazing success wanted to tell everybody about it. So they went in to their provider, and the provider said, numbers are lower, and you're looking good, what's going on? And they're like, oh, I'm doing this diabetes prevention program, and they're very excited, and the providers love to hear that. We have a little success story that Michelle will highlight from one of our practices, but that turns into a little buzz happening internally within that practice. Oh my gosh, my patient came in, she's been trying to lose weight for 15, 20 years. And she just did this program, she lost 32 pounds. She is lighting up. She has more energy that she even knows what to do with. So it's exciting to see that. So some more statistics from the 2-year grant that we received. We have an 88.6 completion rate of the 16-week core phase. So that's once a week for an hour for the 16 weeks. After that, it goes to the 6 months, once a month for an hour. Over the 2 years, I've trained over 67 lifestyle coaches and offered 60 programs within Kennebec and Somerset County. 9 of those programs are associated internally within practices. Patients really like knowing that they're going to their same practice, they see familiar faces, they know where to park, they're comfortable going into that practice, so they enjoy having, and that number is really increasing. So we're really making sure that we're bridging that gap so patients are comfortable going to that setting. So this is another visual that I have here of coaches and sites, delivery sites within the 2 counties. So another really amazing thing that we're doing is that we actually have a large number of volunteer lifestyle coaches. Some of those coaches actually went through the program for themselves, loved the program, had amazing success. And they're like, what can I do? I want to give back to my community. I want to make sure I'm holding myself accountable. And so they want to get trained as a coach. And sometimes those are the most effective coaches because they are in the shoes of the people sitting around the table in that class. So they really are very, very powerful leaders, and they love the programs. They love teaching it. So it's quite a commitment for them. It's almost a year-long program. And I really try to bend over backwards to make sure I give that coach everything they need to make sure that they're successful and they're continuing to enjoy delivering the program. Okay.
So Laura had come to our practices and said, how do we make this more sustainable in primary care? And what we did was reach out to figure out with our EMR report that we had, How can we make that the most useful to get our patients more engaged? So we took our psychologist in one of our practices, and this is brand new, opened him up to motivational interviewing. He takes the report that we have of those at risk, talks with the providers in the huddle, and says, who's most appropriate to complete? Who do you think will complete all 16 of these classes plus the 6 months after? So the conversation happens between those two. Then our psychologist will call them up and say, Dr. Culkins wanted me to talk with you about prediabetes. You know, have you thought about weight change? Have you thought about this? Do you know what the condition is? So he does a lot of coaching and conversation with them. He'll also invite them in to talk about this a little bit more in depth if they need to. He also will take the classes that are around the community and make the best match for the patient. We opened up classes in our practice because we found that patients want to be where they're comfortable. So now we're hosting classes right in our practices to help our patients. We've educated all of our team members, all of our providers. We've put those cards that she's referring to in each one of the physician exam rooms. So the card is readily available to talk with patients as they see them. We're noticing, providers diagnosing more prediabetes, something that maybe they weren't looking for in regular visits. So the extension of the practice is really important. We're finding that, when patients are engaged by their physician in a conversation about prediabetes, the warm handoff huddle, the psychologist interview, are they ready for this change? Are they ready for the commitment? We're hoping that that increases the success rate that Laura has in her participation through the core 16 weeks, but also thereafter. This is Dr. Nielsen, one of our practitioners, who talks here about the cards being readily available. She's taken her patient success stories and sharing those with other patients that may be contemplating change. She finds that having those cards readily available by the computer in the exam room, she's more apt to talk about this class with her patients. Patients are coming in that have had no success in the past, very happy and noticing mood changes. A lot of our providers are excited about this work, and it's something that they don't have to do in that office visit. So it's an extension of the practice. It being free of charge. We have a lot of patients that can't afford these classes. We also have social workers in our practices that will help navigate transportation issues, hook them up with somebody that's going to the class to hitch a ride, those type of things. So our providers are extremely happy with the success that they're seeing and continue to make this more visible to other patients. Here, this is a patient of ours that was referred to the diabetes program. She loved it. She wanted to give back, so she started to be a lay coach herself. She's had great success with her programs that she's running. I think it's like Laura said, having those who've done the class and had success, they're the best teachers. They're their peers. They're not a provider, harping down their throat. You got to change. You got to change. It's coming from that internal motivation. It's all about lifestyle change. It's not necessarily a weight loss program. That's a huge benefit of the class, but it's learning how to incorporate fitness and exercise and lifestyle, fat gram counting, talking about the nutritional piece and really gaining that support from a group of patients together. And Laura didn't quite mention this, but if they had a significant other that was interested in the program as well, she opens it up to them. So they don't have to be a patient and they can self-refer as long as they meet the criteria. And so, there we go. The weight loss. Weight loss is a huge success of our patients. Most all of the testimonials that come back talks about the 15, 20, 30, and you'll see here 42-pound weight loss. So these patients are, they're happy. They're happy with their goals that they've set and obtained. So it speaks a lot for, depression when you talk about patients actually meeting goals and coming out of that rut that they've been in. This program has changed so many people's lives in Somerset and Kennebec County.
I have to share the story. I had one of the ladies in my class. She lost 65 pounds. So obviously we talk about a 5 to 7% weight loss is the goal of the program. Obviously she created a new goal for herself. But she loved to cook. And through this group and having the support of the group, she's like, I really love to cook. And so what she did, she went home, she made another goal for herself, and she went home and altered every recipe that she had in her house to make it healthy. And so that she can continue to cook, but eat the right things while doing it. So she had an amazing success with the 65 pounds, and she's going to keep those tools for the rest of her life, which is really exciting.
Well, maybe you thought they skipped over me and I wasn't going to come back, but you'll actually see that the more important members of our team are the first two that spoke, and I'll say a little bit more about that. Do tell me if I'm not keeping up the slides since they're behind me. But we've talked about what's represented on the slide a couple times today. The work that we're doing has got to be about the whole population. And the work that we're doing as health systems, traditionally our clinical care can only affect about 20% of health. This work that is being done in a program like this is about changing behaviors. It's about beginning to have a greater effect on the overall health of the individuals and the populations you serve. The other thing I'd point out is that this is payer agnostic. And so this is about serving the whole population no matter what the payment for healthcare is. And simply on this slide, what I want to say is this work, we anchor this work in primary care. And you've heard examples of this and how a program like this has got to be in collaboration with our primary care. As we look at the various populations we need to take care of, we need to create these variable delivery systems that really do meet the needs of the individuals, with the population being represented at the bottom of that slide. And so finally, what I want to say as a person at the system level, what you need to do is be finding evidence-based programs that address what the populations you're serving, what their needs are, and then find really good local leadership and support them. So what you need to do a bit is get out of the way, but also we wouldn't be as successful as we've been if we didn't have a local champion really pushing this program all the time and supporting it and overcoming barriers along the way. Finally, this work of training the trainer, it includes our own employees. So the main general health system employees have been participating in this program. And that's one way to create even more buzz, because we're hearing quite a bit. And we as healthcare workers, not the healthiest population in our community. And so programs like this can help a great deal, and then you have to give it time. So with that, we'll move on to our employer partners.
And Anthony and I have decided that since they're doing this so well, we don't need to do it in our companies anymore. This is the most bizarre ergonomic setup I've ever had when presenting, so in order for me to see what's on the slides, I'm going to have to turn my back to you, so I apologize for that. There we go. Okay, the picture on the front of the slide is actually our most recent diabetes prevention group. This was a collaborative effort between Bath Iron Works and LL Bean, and this was our last of the 16 classes, and we had it on a boat. One of our participants was a boat captain, and he took us on a cruise in Freeport Harbor, and we had a healthy meal to go with it, which was just fabulous. We learned so much from this group, and I can say I learned personally so much. I'm going to talk a little bit about this program, LL Bean, and how it fits into what we do at LL Bean, and then Anthony's going to give a different perspective of it, so hopefully it will be helpful to you. Just a general question to the audience. I imagine some of you have had some interaction or connection with diabetes, and given that, what is the one thing you hear that diabetics need to pay attention to from a dietary standpoint? Carbs and sugar is what I heard. So we went to the training for this, and they're talking about fat. And as a health educator and someone who's worked at LL Bean in wellness for 29 years, I was a little skeptical. And it didn't really make a lot of sense to me. Now it does. I was one of the co-teachers, co-instructors of this group, and the reason I did it is because I wanted to understand it if we were going to incorporate it more into our company's wellness programs. And I learned a lot. It's fun when you, I won't say I was wrong. I've said it many times that I've been wrong, but I just didn't understand how this would work. And by actually helping to teach it, I was able to see it on a more personal level, and I'm sure the people from Maine General could speak to this. So, a little bit about LL Bean. I know you know an awful lot about our company and what we sell, but I wanted to make sure you understood our population so you know where this fits. We have 5,000 year-round employees that are benefit eligible. We go up to about 10,000 employees during our peak season, which is now. We are self-insured as an organization, and our health costs are about $30 million a year. We spend about $2 million on workers' compensation costs. Our average age is 50. I'm above average. And we have 2/3 of our population that's female. This is another thing that was so great about partnering with Bath Iron Works, because most of the health education classes we offer are all women, and this class was made up equally of men. It was really cool. It changed the dynamics of the program. Leon Gorman, our president for 40 years, in 1982 spoke at a health conference out in Omaha, Nebraska, and he stated that a business is in a unique and responsible position to effectively enhance the well-being of its employees. That was over 30 years ago, and that's when he started our employee wellness program. I still look at him as a visionary and think he is an incredible man. So that's how we started way back. We now have a safe and healthy living core value. And, click forward. Thank you. See, I told you this was going to be a problem. That's Leon in the middle. He was climbing Mount Rainier. Fabulous guy. And this is our safe and healthy living core value. And what it says is we believe healthy people lead fuller, more productive lives. Our employees and other stakeholders should feel their association with their well-being contributes to their health and well-being. So I want to get to understand a little bit about our program so that you can see where this other program fits in. We've had a fairly comprehensive program for a long time. We have on-site fitness centers. We offer health education and activity classes. We have a comprehensive health risk appraisal program, smoking cessation. We have tobacco-free worksite, an employee outdoor club. So a lot of different things, an employee assistance program that's heavily utilized. We have all these programs, but guess what? We still have health risks. The people in our catalogs that sell our bean boots and our hiking gear are not representative of our employees. So, see, that wasn't, she's trying to give me the nudge. I thought she tapped me, and I'm like, what? Yeah, could you do that? Obviously I can. I was never good in aerobics either. You know, aerobic dance where you have to move your upper body and your lower body at the same time did not work for me. Thank you, Anthony. So, what we're looking at now, I know you're sitting in the row back there and you're saying, I can't see that. This is boring. Okay, let me tell you. You only have to look at the colors. Can you see kind of the color differentiation way back there? Okay, so we work with WebMD for our health risk appraisal. We do biometric screenings and we get the results. And we get a report, a 36-page report for each area of the company that has 50 or more employees. So the first year that I was looking at these results, I'm going through the information, one report, and I'm trying to figure out, well, where are my biggest risks? So I created this little chart. And what we have here is the column that is, well, looks kind of whitish. It's supposed to be light blue to the left of the green line. That is our 2013 results. Down the side, we have all the health risks, smoking, weight, A1C, glucose. Across the top, we have all the different areas of the company. The first column is our 2013 company average. The second green column is our 2010 average, the last time we've done biometric screenings. And then anything that's white is below the company average. Anything that's yellow is above. Anything that is pink is our highest risk area of the company for that specific risk. So I know you can't see it, but what this does is it identifies for us what areas in the company have the most risks. So normally, we would have the red line up and down, highlighting our Bangor call center, because we have 1, 2, 3, 4, 5, 6, 7 pink areas in that one location. And so we've done special program targeting there for an individual population. What I've circled this time is going horizontally, and I know you can't see it, but I'll tell you what it is. It is glucose levels and our A1C levels. And what I can tell you is from 2010 to 2013, both of those numbers have increased by 25%. So our employee The number of people who have glucose levels above 125 has gone from 4.6 to 5.8%. And A1C is equal at 5.8%. We didn't do it in 2010. Our glucose from 100 to 125, which is pre-diabetic, 15.7 to 19.2. So significant increases, and unless we do something, we can expect that to continue. Our average age is 50, as I said earlier. Our obesity rate, 35%. In Bangor, our obesity rate, not overweight, obesity rate is 71%. So you can see we're dealing with an at-risk population. So enter the diabetes program. So I'm going to speak a little bit to this, specifically about how we found out about it, how we started working together. I had heard about this program. I knew it was developed by the CDC, so I thought it's got to be a good program. And Anthony actually asked me, called me up and said, would you want to come and talk about this? And we met, and it was one of the most motivating meetings to be working with another employer to talk about how we could work together to help our employees. So we decided, yes, we wanted to do DPP. We went ahead and held a training. It was a joint training between Bath Iron Works, IDEX, Intermed, and LL Bean. We trained, I think, about 25 leaders to go out and work with these classes. Then we offered both a class for BIW and LL Bean, and then also we did a separate one up in Bangor. And I'm going to report out on that a little bit. They're so good. Okay, so a little bit about the instructors. Up in Bangor, we did a single instructor, and for the Bath Iron Works and LL Bean class, we co-led the group. We had 15 participants in each class. In the Bangor one, they all finished. In the Bath Iron Works LL Bean class, only 11 finished. One of the tips is, you probably shouldn't sign your spouse up for a weight loss program without telling them what it is. She came one time. So, interesting. The other thing is, a lot of people don't know that this is a weight loss program. They see diabetes prevention and they think they're going to come learn about diabetes as an educational program. They don't realize that it focuses on reducing your fat intake, reducing your weight, and increasing your activity. So if I can give you a tip, it would be make sure people know what they're signing up for. We met for 16 weeks, once a week for an hour, and then 6 months of post-core for once a month. I would say some of the lessons, and I'll talk more about the learnings later, but the lessons are that the pace of the program is very important. And as you go through that, tracking, how many people have ever tracked what they eat? How many people like to do that? Well, that was a critical component of this program, and the reason I think it works so well is the instructors give feedback on that and return it back every week, so people know they're going to be held accountable, and that was a real critical piece of the program. So this is some data I wanted to show you. So we were told, when we looked at the first page of the manual, the diabetes prevention program will result in a 7% weight loss by increasing your activity to 150 minutes a week and decreasing your fat intake. So that was the focus of the program. And what we saw with the Bath Iron Works LL Bean group is a 7% weight loss. Isn't that amazing? Woohoo! So we didn't find that in our other class. But it was so cool when we looked at the data and started to understand, how did this work? And how does this compare to Weight Watchers? And how does it compare to our Bean Strong group that we did for our Bangor population? One of the things I like about this program is it's sustainable. You train your people, you can offer this program. It doesn't necessarily cost a lot of money. So it is a sustainable program. We certainly see it in our efforts going forward. But it was great to see that the results were kind of showing what we were looking for. So average pounds lost for this group was 13, and our average percentage weight loss was 7. If you go to the next chart, our Bangor population, which, as I said, remember 71% are obese in that area. They had 15 participants complete the program. The average pounds lost, 12.4, almost the same. But they were at such a higher weight to start with that 12.4 pound loss was only a 3.6% weight loss. Still positive. You know, we had really good results, really good feedback from the participants. So this is something we're definitely going forward with. But it was interesting to see how a different population is affected by the same class. The last, actually I have 2 pages left, the key learnings. This was amazing to me. The pace of the program. They don't introduce exercise till 5 weeks into the program, and I couldn't understand why. And they also don't even ask people to count fat till the 2nd week. So the first week, all you're asking them to do when they eat is to record what they're eating. Not how much fat, not how many calories, just write down what you're eating. The 2nd week, you give them a book about counting fat grams, and then they do tracking and the fat grams. And then the next week, you talk a little bit about possible substitutions they can make. Finally, week 5, you introduce the exercise. You know what? That's all people are ready for. How many in this audience have a health background in some capacity? Health education, medical? Well, you know, we need to be quiet. It's amazing. I went to a program in Freeport about smoking cessation and trying to take your company tobacco-free. And I was one of the speakers, and we ended up with 12 speakers and 2 participants. It was a great group, I'll tell you. But I sat there in the audience, or in the group, we ended up just forming a circle, and I said, let's just ask them what they want from us instead of trying to do our presentations. Well, try and see 12 health educators be quiet. You know, it's such a learning for me. The best part of this program is the participant involvement. You know, sometimes as health educators, we get in the way of facilitating a group. And the biggest learning for me and for our department at Beams was really understanding that the success comes from the participant engaging in the material you're presenting and sharing their own experiences. You need to know how to kind of manage that, because you can get that one person who monopolizes the conversation, but overall, very, very impactful. This group at the end was so bonded, they started their own private Facebook group to stay connected in between the monthly visits. So very, very positive. Maintaining the integrity of the program. 16 weeks, the first time we heard it, I said to Anthony, well, why don't we do 8 2-hour sessions so it doesn't take so long? Well, it takes so long for a reason, because the people need that length of time to take in the information and make it part of their learning process. So it was really good. And I think the one other learning there would be, when we got to week 5 and we said, okay, your goal this week is 60 minutes of activity. We told them 4 days, 15 minutes, 6 days, 10 minutes, whatever works for them. We had 3 people in the group not meet that goal. So imagine if we'd gone back and asked them to do that the first week in addition to tracking. You know, very, very interesting. Make it your own, even though there are weekly lesson plans and there is, you know, you need to stick to the structure of the program. You can have it on a boat. You can have a healthy meal along with it that the individuals provide. You can ask somebody to apply the lesson to an experience they had in the previous week. There's a lot of ways to make that your own, but I think staying true to the structure is important. And then the last thing I'll say is next steps. We are definitely continuing. We look at this as a pilot effort. Everything we do is a pilot. It's easier to get it approved that way. So we are offering 2 new classes right now, both in our fulfillment area, our distribution center, that kind of high risk for this. We are going to continually assess the data, make sure it's having an impact. And then we hope to integrate it with our Healthy Lifestyles program. We are in the process of moving towards an outcome/action-based model. And this would be one of the actions that people could take to get credit. And then again, I also work with our occupational health clinic, and our goal is to integrate this program so that our providers in the clinic are referring out to the programs that we're offering. So, last item there, if anybody has information to share, we are expanding our home agent population. We currently have 300. We will eventually have 500 in Maine, and we're also expanding our retail stores outside of Maine, so it's harder to reach these people. So maybe we can refer to Maine General's classes, but anybody else has good ideas about how to keep this on a broader journey, I'd love to know.
I'm going to ask Susan to click through for me. Good afternoon, everybody. I'm the guy that's going to liven things up here a little bit. But I think from what Ron was saying this morning and what we've been talking about, or my co-presenters have been talking about the last few minutes, is that it's all about collaboration. The LB and BIW partnership really started with a cup of coffee, right, at Starbucks in Cook's Corner. And I'm excited, and I know Susan is, to continue that relationship. It also started with me calling Laura up to talk about what they're doing as really a model for us in the state and probably around New England and beyond that. So I'm excited to be here, and I was really excited to hear Ron and really the other presenters today talking about collaborating more together. So I work at BIW, although I'm an employee of Maine Coast Hospital. BIW recognizes that while we build the best surface combatants on the planet, they're not in the business of healthcare and health improvement. So they reached out to Maine Coast Hospital and said, hey, how do we run a good wellness program? So they hired me, and we have a team of health coaches on site. Maine Coast Hospital also does our yearly on-site biometric screenings, and we've done that really since 2011. So one of the things we found out early on, the first couple of years, is we weren't really getting the full story with these blood sugar numbers. We couldn't have people fast on site because, as you can imagine, we have crane operators, we have grinders, we have people, we have welders, underwater welders, a lot of people working in risky environments, and we do not want them fasting throughout the day. So we decided to do A1C, and as most of you know, you don't have to fast to do A1C. So in 2013, we started doing A1C, and as you can see in the circle, we found out that in 2013, in fact, 55% of our employees that we screened are at risk for developing diabetes. And so obviously we had to figure something out, and as you can see, our BMI risks are very high as well. 82% of our employees are either overweight or obese. And then the next slide. Thanks. So this is sort of some specific numbers around our costs. And again, I know I'm sort of preaching to the choir or whatnot. I know a lot of you guys know how expensive diabetes can be, but until you see it like this, and 4,000 compared to 14,000 seems incredible to me. We've got 6,000 employees, so if you just did some quick numbers, you can see that this is going to overwhelm our overhead costs as we bid for ships and make us more competitive if we can reduce our overhead costs. And then the second bullet there, diabetes was the #1 driver of pharmacy costs in 2013. That blows me away, especially since before 2013, we weren't seeing a lot of diabetics come through the screens. So I won't go into a whole lot of detail. I think that Susan talked a lot about how important our partnership was. We did our class, both our coaching class and beyond, and I think the key term and the key is here is it can't end with just our relationship. We've got to expand it beyond that. And then the next slide. So our goal at BIW is to try to offer 4 classes by the end of 2014. We're getting ready to launch our second class in collaboration with Martin's Point over on the Farley Road in Susquehanna. And I'm confident if we can continue to build relationships with providers, then we can launch a couple more classes by the end of the year. And I think I've got a couple success stories I want you guys to watch on the video, but wouldn't it be cool if we get to the point, at some point, where we're all sort of behaving like how many places at Maine General are, where not only the providers, but the systems are saying, okay, how can we, what does this patient or participant need to get them into a healthy place? But when can we get to the point where we can see where our healthcare system or health improvement system isn't just limited to providers and systems. It's also where schools have a role, the physical education staff, the health staff in schools. How can they see this in respect to the DPP? How can they utilize these programs to promote health in the schools and beyond? So we've got a ton of opportunities here. So I wanted to picture of our success stories. So we consider a part of a comprehensive on-site wellness program. We consider the diabetes prevention program to be a part of a comprehensive diabetes program. And we cannot do it without the providers. And I think Trevor or somebody was
I ended up finding something in the mail, a gift in the mail with an invitation to.
So these are two success stories from our diabetes prevention class that it's only 3.5
I believe
years.
my A1C was a little higher, and also I was heavier then. And they have a program available, the diabetes prevention program, that kind of set me on the right course. I had an A1C that came back a little elevated, and knew I needed to do something to get a little healthier and stay around for this little guy, and we had 2 others.
How did I get involved in the program? Well, it started by going to the screenings and having blood work done and all the weight and measurements taken. From that, we saw that my A1C was kind of creeping up, so I got hooked up with a health coach.
I ended up finding something in the mail, a gift in the mail, with an invitation to go to a ladies' night for BIW and get a screening. And at the screening, I believe my A1C was a little high then also. I was heavier then. And they had a program available, the diabetes prevention program, that kind of set me on the right course to getting healthier, and hopefully my A1C will be down, which I'm sure it will be. So learning a new lifestyle and a new way of living.
The health coach has been helping me here for a couple of years, and the DPP opportunity came up recently. She recommended that I come to it, and so I have, and it's been a good experience.
I brought my girlfriend Bonnie, and she's impressed by how far I've come and the progress that I've made. She doesn't have the pre-diabetic stuff, but just giving her some information on how she can drop some weight too. I think it's something that everybody could do.
From the health coaching, I've tried to make some changes, tried to push the health coach with changes. And then I further that in the DPP.
The health coach that I have is Betsy, who's running the program, and I also meet with a dietitian, Sarah, and she helps me make some choices as far as how I cook and options for different things to eat for meals. I'm trying to get enough reps sometimes eating the same thing because I know, what my fat content is and my calories. Having different options for different things and different meals and different things.
The DPP really focuses on preventing diabetes. You'd think it would be focused on getting rid of sugars, but actually we focus on minimizing our fat content and increasing activity. And that's really to get weight loss down so that we can prevent the onset of diabetes?
Oh, I feel great. I have more energy. I just all around feel like I'm on a great path, that I'm doing much better.
I've changed my eating habits a fair amount to minimize the amount of fat, try to stick to their goal, increase vegetables, things like that, all the good stuff you're supposed to do. And then I've also increased my activity a lot. Bought a bicycle, something that I thought I'd like to do, and I've done a lot of biking, and that's made a really big difference.
Thanks so much.
Yeah, I've been going for a while, but as you can see, they're both jazzed up. There's usually two participants in the class that together. And the last thing I'll say is two things. Just reiterate, collaborating together. If you have questions, I think, obviously Nate and Laura are probably the two experts in the state, and there are others as well that can answer questions if you want to launch something. And then, it would be cool if we got to the point as a culture where people could understand that they don't have to live with a disease, or they don't have to manage their disease, that they can recover their health, they can recover their wellness. So, and that's where I get jazzed up, because these participants here that you see on here, on this page, on this slide, absolutely have. So with that, I probably would have taken questions. Nate, I'll turn it over to Nate.
Oh, thanks so much to everybody here on the panel. That was fantastic information. So yeah, we wanted to now have open it up for discussion with the time we have remaining from the audience here. Some of the things that we brushed over today is like the actual structure of the program. We heard a little bit about that. And that's typically a big question. But let's go ahead and take questions from the audience. Yeah.
Hi, my name is Ron. Really a big challenge for what they can go over and done. It's a bigger challenge to see that results. Because they hit about real probably we start with I don't know how you do it. What you're doing is called evaluating. That's part of the program. And follow people. Actually, you're out. So you're out. There are people really have issues with the started because I'm going to have to catch an audience. Hopefully, you get this all here. You have to help 6 months and just follow it for 6 months. You don't know how it's going to be. How many people don't have the treatment to develop this program. There's no company that just made it. What is that? All the data will tell you. Every diabetes prevention program across the spectrum.
I would say, first of all, I think what we generally is doing is giving more support to the community. And I agree with what you're saying. We are following up with our employees or participants. They'll be retested up until 11 months because of the way the program works. But it means we do follow up, and that's what I said by the impact and the and yeah, some people will stop. One of the things I shared earlier is the data that we look at LMU for the past 3 years tells us things that we don't necessarily see at the time. And one of the things we saw with our smoking rates is that we've gone from 23% down to 6%. But the periods of time that we had 25% and 50% reduction in smoking rates was when we changed the comments there. So that's smoking cessation programs freezing. I would say, first of all, I think what Maine General is doing is giving more support to the community. And I agree with what you're saying. We are following up with our employees or participants. They'll be retested up until 11 months because of the way the program runs. But that means we do follow-up, and that's what I said by the impact and collecting data going forward, because we do look at that. And yeah, some people will stop. One of the things I shared earlier is the data that we look at LA for the past 30 years tells us things that we don't necessarily see at the time. And one of the things we saw with our smoking rates is that We've gone from 23% down to 6%. The periods of time that we had 25% and 50% reduction in smoking rates was when we changed the environment. So we had smoking cessation programs, free nicotine patches and gum, but when we went tobacco-free in our buildings, we went from 20% down to 15%, and when we went tobacco-free on our grounds, we went from 12 to 6. And those have been maintained over time because we measure it every year. It's a little bit more difficult with diabetes because, you can look at impacting the cafeteria, which we have. You can look at impacting what, this is funny, we're doing a recognition lunch tomorrow for our peak hiring because they've just hired 4,000 people in the last 2 months. And so I said, let's celebrate, let's recognize them with a healthy lunch. I got 4 people signed up to bring stuff in. So I had to send out another memo saying, it doesn't just mean carrot sticks and celery sticks. It's hard to make changes. But, I look at what you say with the same thing I look at for people who say you shouldn't provide incentives to get people to do wellness things. But incentives get people through the door, and they expose people to programs that they might not otherwise participate in. With this diabetes prevention program, they're learning. It's a year-long program. I do have faith that this program will help some people maintain those changes, and not everybody, but I think it's a program that's doing something different than what I've seen with Weight Watchers or with some of the other programs. And I think that's because they're creating support systems.
I just wanted to point out this poster up here to the left of me is a overview of the 2-year grant that we received when we launched this called the Up and Running Diabetes Prevention Program. We did extensive evaluation of different types of things and evaluate different types of things. For example, a shift in emotional well-being over the year-long program, which was really interesting, and there was definitely a huge shift. So if you're interested in that kind of stuff, you want to check this out. But we do, since we have 3 to 5 different programs starting every month. We have, it's on a rolling basis, so it is very challenging sometimes to collect that in that way. But those individuals that have graduated from the program and we post for some of these sessions, we invite them to continue to come to other monthly sessions that are established. We try to get them hooked up with other community resources that are going on that are either discounted or that they can go for a scholarship to get plugged into, still increasing their physical activity, making sure that they're being engaged in changing some of those things like juices and veggies, and just getting plugged into those other resources that we have. We have a really great resource center that started at King Mineral in the last year or so. So we're volunteering to have that as well. But our next step with this program is getting into those extremely rural communities. Thankfully, we just received some additional funding from the federal CDC to enhance this. But as a system, and Barbara, when you talk to this, is that we in 2 years ago, a very short turnaround to get things really moving, and the system saw this program with the great success that it had, and really said we need to make an investment and continue with this program because it's having such an impact on our community. So even though that's why, as a sustainable model, you look at, we don't have all diabetes educators teaching this class. We don't have all nurses teaching it. Some of them. But, I have, over 26 volunteers teaching this program. So they're volunteering their time and really making a huge impact on their community. And the other thing to kind of piggyback off of Elaine's story and Bath Ironworks is, having a support person there with you to go through these programs is really key, because then you can make sure that you're feeding off of each other, supporting each other, even when you graduate from the program. I think that's really key. We saw great success with people, partners that are on in this program, and want to continue to make new goals for themselves and support each other, and make sure that they're seeing what the changes that they've made. So
here the challenge that this is really sustained beyond 18 months, 2 years, 5 years, 10 years, because this really is about population health in the long haul. So I sort of accept that as a challenge, that we've got to do some more work to think about the long term.
This program, so when they come in, the provider's like, great job, now I'm going to work with my nurse, you know, you want them to come. And I think, you know, we can look at primary care as a model where we integrate chronic disease management, case managers in the practices, nurses. You know, we're using a lot of behavioral health interventions to see the impact on diabetes management. And, you know, I can only hope that this program is planting the seed in at least a few patients so that, you know, they don't eventually develop diabetes and we prevent some cost. I think it's a long shot to say, you know, we'll know exactly what the outcomes will be on these particular people right now for the 10-year long haul, but it's definitely interesting to see that the seed is planted and that primary care can kind of carry that patient through the rest of their life. You know, the good thing is in our system is the providers get tasks in their EMR that this patient's just now, you know, completed this program. So when they come in, the providers are like, great job, now we want to work with my nurse. You know, you want them to call you on a monthly basis to keep in touch, and then they can go back to the course. It's not that they couldn't. So we're trying to keep a hold of them as well.
And I'll just get to the second part of your question, Ron, which was, you know, what are we doing to help provide technical support to facilitate all of this? And part of what the SIN grant is allowing us to do, and as well as our US CDC funding opportunity, is to have folks like myself out there providing technical support to all of these groups who are scaling and deploying this. We're also trying to help them operationalize it for their organizations so that they can really set up a sustainable model so they can have this continue for, you know, multiple years. And I mean, most of the programs here in the state have only been running since August of 2012. So we are really, really young in this deployment. But we're pursuing things like trying to establish policy and protocols that incorporate, you know, this lifestyle behavior movement, you know, in the way that they're managing their patient populations in different healthcare settings. That you know, some of the things that this group just talked about is they're trying to affect environment, and we're hoping to facilitate those same types of supports and mechanisms to be put in place in the care settings with other employers and in community-based systems to facilitate lifestyle behavior change outside or post this program.
And I'll just add on, because I can never stop talking. What you're saying is correct, and I'm not arguing that, but I do see some opportunities through this type of program. One, that they're not just depending on the instructor, they are depending on others, but we just recently had our first post-core class in Bangor, and one of the gentlemen in that class said, you know, I really miss these meetings because the people in this class get me. They're my support. The advantage of a workplace is he does see those people on a fairly regular basis. Now, he won't when he's a home agent, but you know, that kind of environment does matter. Creating a community that's supportive. You know, I've been down to my nephew's baseball game in Connecticut 2 years ago, and I was standing behind the bench and the coach was smoking on the Little League field. And you know, we don't do that up here in Maine. We don't allow it. And you know, you can say what you want to say about governmental rules, but you know, the more we support healthy environments, whether it's from a food standpoint or a smoking standpoint, it just makes it easy to do the right thing. How many people use their phone when they're driving? Oh, come on. Would it make a difference to you? When I drive in New York State, it's illegal. I don't use my phone when I'm driving in New York State. But I do here. And that, shame on me, but sometimes things like that help.
We had another question, yes?
I had a couple. The 60%, first of all, thanks for this presentation. I think it's great work, by the way. The 60% that in Canada kind of stood out, and I think going in forward it was 55%. So my first question is that typical? Is that close to national average? And then what portion of
Yes, you are correct, that there is a significant number of individuals within the population who are at high risk. Typically, because I've been fortunate enough to have touch with not just some of these folks, but others around the state in trying to help them understand who's eligible for this program, we are seeing on average close to 2/3 when you dissect the population down and look at just high risk or indicators for pre-diabetes. So a significant number of individuals would fall into eligibility. Also want to make sure I also say moms who have had gestational diabetes with any previous pregnancy all fall within that eligibility as well. Sorry, 2/3 of any of the analyses that we've done with any of the folks that they are finding that they have close to 2/3 of the population sector that they are looking at who would fall into eligibility for this program. So presenting with either prediabetes or 2 or more risk factors for prediabetes.
Two-thirds of the main population by definition of weight is
Correct. Yeah.
How many of those 2/3 are reaching expense?
Oh, thank you, yeah. Of those right now, with this program so far, as of July, we've had only 400 Mainers who have gone through and completed the program and been a part of our statewide analysis. But that's July, and that's not taking into account the reach that employers like LLB and BIW have so far, because they're not a part of that analysis that we have access to. But that number is growing as more and more programs, and especially groups like Maine General, are offering 2 to 3 more a month. And as far as scale or size of those groups, they typically hover right around 8 or 10, and typically don't exceed 16 individuals in a particular group.
So the second part of your question, in regards to incentivizing, I'll let Susan talk about maintenance. I don't know what we're doing. So BIW in the past has offered premium reductions if you do your HRA, your health risk assessment, and your annual visit to our, and those have been eligible for salary population only. We have 4 represented unions. We haven't done that with those guys. New this year, we offered to everybody a $25 value card, LB card, or a mini Lebanon, also from LB.
We offer BIW gift cards.
Or some other choices, with a $25 value. So those are the only things we offer for incentives. We are getting ready to launch in the next few weeks some incentives for our salary population around weight outcomes. And if anybody here knows a BIW salaried employee, don't tell them until next week. Let the cat out of the bag. So, and if Michelle's here, I'm in trouble. So, we stayed away from incentivizing participation with our coaching program because we're getting enough participation, enough percent that are coming through our on-site screenings to sign up for coaching where we don't need to incent that. And my personal philosophy has always been, let those that sit down with a coach be at the right stage of change so that they're ready to make a move when they sit down with a coach, rather than I'm just here to get my $25 or my incentive, so I'm going to meet before time. I'm not saying that would happen every time, but there's a good chance that it would. So that's what we're doing at That Works.
I would say we have a similar program. We have a significant discount, premium discount for anybody who participates in our Healthy Lifestyles program. We have 91% of our benefits eligible employees participating, and what that means is they go through a biometric screening on site, they do a health risk appraisal, and they have a minimum of 1 call with a health coach. So that's current, what we're looking at going forward, and again, we can't speak because we haven't communicated it yet. Employees have an idea of what's coming, but we are looking at more of an outcomes action-based model. We'll keep what we have, but for a health savings account contribution that we want every employee to get, we're looking at either meeting outcomes or taking action. And this is the type of program we would tie to taking action.
Yeah, it seems like it does.
Yeah. Good point. That's what I would have said.
There's a question. Please.
Hi, I'm Pat Ruiz, I'm from Indiana, and I have two questions. First one is to Laura. I'm sitting here, Laura, one thing about your job security, I'm kind of worried because I think your full-time position is related to the grant, and we need to sustain you from everything I've heard here. What's going to happen next? How are we going to sustain this program, you and the program? It's my first. Okay.
My funding ended September 30th. But the Prevention Center and our Community Health Fund and Maine General as a whole, again, saw the impact that this had on the community and plugged me into their budget for the next fiscal year. In the meantime, our department is very busy in grant writing. So in the process of juggling all these balls and making sure everything's rolling and all that good stuff, we wrote another grant and received $1.46 million for the next 3 years to continue and enhance our efforts for the diabetes prevention program. Also beef up our other chronic disease management programs within Kennebec and Somerset County. And we're now adding a tobacco cessation component to making sure that people in our two counties are receiving the additional help that they need to address clinical protocol.
So it sounds like this will continue to be free for some period of time.
Yes, yes, and and from the start, if anybody knows Natalie Moore, she's a pioneer in the prevention world and she's an amazing person. But she said, we really need to break down barriers for people. We can't have people, saying, this is $50 to enroll in the class, and or you can do a scholarship or whatever. It's been free from the beginning. People really enjoy that. We work very closely with KD Cap Transportation to make sure that they're getting the transportation to these classes. They've added extra routes to cater to classes that are going on at different times throughout the day. And also are trying to offer free transportation to some individuals as well to try to get them to those programs too. So, like Anthony said, that the community support is needed. We've got to join together and make sure that we're all on the same page with offering these types of programs for free to people. The partners in the community too. Merrill's Market in Waterville is a market that supports locally sourced food. I hold classes there because it's a convenient location for people to walk to. They have offered space for free. I've also engaged other private fitness facilities. They've let me use one of their group fitness rooms, and we bring tables in every week and chairs every week. And so it's that community effort that really makes a huge difference in making sure that we're reaching people in these unique areas that they might not be able to get to the medical center each week. Maybe it's easier for them to go 2 miles on the road, or maybe they could walk. So we're really trying to diffuse those barriers and making sure people have the access to get plugged into these programs.
Thank you. My second question is for Susan. As an employee at Maine Medical Center, I'm now in the habit of doing my biometric thing every year. And I've heard a little rumor that we may be not doing it every year. We might do it every 2 or 3 years. Can you tell me what the trend is and what your institution is doing on that?
Sure. My recommendation to BIW would always be to do it yearly. We have less than 40% of our employees that see their provider yearly, which is a problem, obviously. So this, at least they get in front of a nurse and one of our health coaches once a year, and obviously one of our goals is to get them in to see their primary care provider. A lot can happen in 2 years if you go that long without, getting screened. It might be different without being screened.
It's expensive to do screenings, and when we first started, we thought we'd do it every other year. So we did it in '07, we weren't doing it in '08. In '09, it was a bad budget year, so we cut it. We did it in 2010. We didn't do it in 2011. 2012 was not so good budget-wise, so we did it in 2013. Now we're doing it yearly. And what I was able to do, one of my favorite graphs that I have is it shows blood pressure, cholesterol, glucose, and one other thing. Oh, BMI. So that BMI, and what it shows is 2010 when we measured, or 2007 when we measured, then 2 years of self-reported, and then a measured year again. And I'll give you just blood pressure. It shows 21% of our employees have high blood pressure. That goes down to 10 in the first self-reported year. It goes down to 5 in the second self-reported year, and went back up to 20 in the measured year. No change. It's not that people were lying, it's that they don't know their numbers. And it takes repetitive opportunities for people to start understanding what those numbers are. And if you want them to take action on their health, they really need to know that there's a need for that. And we really try and encourage people to have a provider, to reach out to the provider, to share the results with the provider. So that's what we're looking for, but the numbers are important.
I have two things to add, actually. Cost is obviously a significant issue for every organization, but I would, again, the collaboration thing. The local hospital, Lucas Hospital, does a great job with staffing our screenings, but also VAW's looked at other vendors, and Midcoast Hospital is a local vendor, and they're like half the costs of some national vendors that would come in. So I would, if that's an issue, I would certainly look at that. The other thing is, I'm just going to piggyback on what Susan said. Initially, when we started doing screenings on site, I was one of those people who was hesitant to say that using a screening, just a screening event as an intervention would make a big difference, but we're absolutely seeing migration of risks in a positive area for those that are just doing the screenings. You take away the people that are doing the coaching and the screening, and you separate them, just the individuals that are doing the screenings are improving. So, I would encourage you to do them every year. There's definitely an ROI to it.
Yes. Andy?
Any pickup by healthcare plans in the state of this program? And secondly, you have an event coming up in November.
Absolutely. So far here in the state, we do not have any individual payers who have said, look, this is something we're going to cover. And no real surprise there. What we are trying to do is we're trying to help health systems, employers, actually figure out how to bring this to those payers so that they can have consideration towards making this a part of their book of business if they're an employer, or make this a part of how a health plan would be designed if they're a payer that they're going to offer this to an audience of potential purchasers. So we are now embarking on, like as we enter year 2 of the State Innovation Model Grant, starting that work, in particular reaching the payer community and trying to understand what are the efforts, nuances, the tools that we need to help put into place in the way that we are growing this. We really started with infrastructure initially, and now we're getting towards that point of bringing this to what type of payment reform efforts could this be blended into. So we're really focusing on what could be, how can we put this into an accountable care organization structure and build something around primary and secondary prevention rather than just focus on high utilization. And those are some of the things that we're going to use to get to that payer community.
Can I just jump in there? I'm sorry. I was just going to piggyback on what you said. There's another opportunity that I don't want to lose sight of. Laura and what they've done up there have really sort of paved the way for a model that I think would work. We may not need, and again, I apologize, Nate, if I'm stepping on your feet, but this might be a good idea, as Ron was saying, who knows. But we may not need to pay for this. If we got a group of organizations together and in a collaborative effort to hire somebody like Laura for regions in the state, and we use this coach model where coaches or participants go through the program and then they're coaches later on, you know, it not only would it speak for the fidelity of the program, which we've all talked about is important, but it reduces costs. So that might be an opportunity as well for, especially in some areas that, you know, may not be able to afford the staffing for something like this.
And then lastly, thanks, Andy. I did want to take a little bit of time here to talk about a new event that is coming up in November. So on November 17th, we will actually be holding what we're calling the National Diabetes Prevention Program Forum, NDPP Forum. That's going to be held here in Portland over at UNA. And it's from 1:30 in the afternoon to 5:30 p.m. We have a fantastic agenda laid out for that. We have Dr. Ann Albright from the US CDC joining us to help deliver the information around how to bring this to our payer community in particular, but also help the other efforts around the state with this scaling within communities and health systems in bringing NDPP to Mainers in different regions around the state. Also, we're fortunate to have Andy join us as well as part of that part of that program, and the American Medical Association will also have an address for us. So please encourage, if you are a business, if you are a health system representative, and you need help swaying your leadership in understanding how they can potentially apply an effort such as this, they should be at that NDPP forum. So please send the save the date went out. If you haven't received it, my business cards are up here. Happy to forward it to you. Hope all of you can join us at that event as well in November.
Please join me in thanking our great panel.